Thanks so much for joining us this morning for the American Physical Therapy Association's briefing on treating pain and preventing opioid addiction. I'm Katie Neese, Executive Vice President, and I'm really excited about the information our panel is going to share with you today. APTA represents the interests of more than 100,000 physical therapist assistants, and students. Our members do everything from helping an infant with cerebral palsy learn to walk, helping high school and college athletes prevent and recover from sports-related injuries, and helping adults recover from spinal cord injuries or falls. Physical therapists treat pain through movement, hands-on care, and patient education, and by increasing physical activity, you can also reduce your risk of other chronic diseases. I'd like to thank Representative DeLauro for sponsoring today's briefing. Before I introduce our panel, I'd like to share a couple of thoughts with you. One, the presence of pain is one of the most common reasons people seek health care. Two, addiction is really hard to overcome. And research validates that the pleasure response, that the pleasure response in your brain to drugs can be up to 500 times more powerful than the pleasure response delivered by food or sex. It's pretty astounding. Three, too many people are dying of opioid overdose. In 2016, 42,000 people in the United States died from an opioid overdose, including more than 17,000 whose deaths were attributed to prescription opioid overdoses. More people need greater access to non-pharmacological approaches to pain management. Physical therapists are expert in musculoskeletal systems. They are expert in pain management and can help someone with acute pain prevent that pain from becoming chronic. We need better prescribing practices so that a prescription to PT is more common than a prescription to an opioid. And finally, public policy should support approaches to pain management so that focusing on treating the source of pain when it can be identified rather than simply delivering a prescription to mask the pain. So it's not just us that's saying it. These statements are backed by research. And in your packet is a summary of these things, but I just want to highlight a couple things. One, patients with low back pain who saw a physical therapist at the first point of care had lower utilization of high-cost medical services, lower opioid abuse, and lower healthcare costs compared to those who saw a physical therapist later in treatment or never saw one at all. Early physical therapy was associated with decreased use of advanced imaging, additional physician visits, surgery, injections, and opioid medications compared with delayed physical therapy. Early physical therapy for acute low back pain may reduce health services utilization costs and opioid use and improved health care efficiency. And early physical therapy was associated with significant reductions in long-term opioid use and lower amounts of opioids for patients with shoulder, neck, knee, and low back pain. So what can you guys do to help? APTA wants to work with you to have the discussion, to reframe the discussion on the opioid crisis to begin with the beginning. We want to make it easier for people with injuries or pain to get access to non-pharmacological treatment like PT. And there are at least 3 steps to achieving this goal. First, patients, athletic directors, coaches, and prescribers need to know about alternatives. Financial barriers like copays and deductibles need to be reduced, and patients need access to person-centered multidisciplinary care. So now I'd like to introduce today's speakers, starting from my left. Jen Bambro. Jen in 2004 thought she had no injuries from a car accident that she had when she was 19. However, the next 4 years, she experienced serious pain that prohibited her from continuing her gymnastics and coaching. Jen was given pain medicine, but she didn't like how she felt when she took them. Because the source of her pain was difficult to identify, her healthcare professionals told her she was faking her pain. Ultimately, Jen found a physical therapist who continued to help her manage her pain, Her experience with PT led her to earn a doctor of physical therapy, which she completed just last month, so she can now treat patients who experience acute and chronic pain. Followed by Jen will be Sarah Wenger. Sarah is a physical therapist and assistant clinical professor at the College of Nursing and Health Professions at Drexel University. Sarah will discuss how multidisciplinary pain management programs can offer alternatives to opioids and help wean people off medication. She leads the Power Over Pain program at the Stephen and Sandra Shelter 11th Street Family Health Services. This psychoeducational program is tailored for minority and low-income patients experiencing chronic pain, many of whom are also addicted to painkillers. And finally is Cindy Wide. Cindy's a high school science teacher from Avon, Indiana. Her middle son, Elliot Hughes, suffered an injury playing high school sports. His first course of action was a prescription for opioid. Over the course of the next 9 years, Elliot battled a heroin addiction that included nearly 10 near-fatal overdoses in jail. Elliot had hoped to be with us today, but unfortunately is not. So, Jen, I'm going to start with you. Tell us what happened immediately after your car accident.
Well, immediately after the accident, I thought I was okay. It was not a very serious accident. It was a rear ending. And I went to a chiropractor because I was concerned about the financial ramifications of going to a hospital to seek medical treatment. That evening, I started to have some symptoms of pain and some symptoms that went in of tingling that went into my hand, but they weren't severe. And the symptoms continued to worsen over the next 6 months to a year.
Great. And when you started feeling this pain, what were the consequences of the pain?
Initially, I was having the pain, and I continued on with my normal life. But over the next few months, I became fearful that there was damage associated with the pain, and I started limiting my activities. I stopped doing gymnastics. I stopped coaching. And as the pain got worse and worse and I stopped doing more and more things and being more fearful that I was damaging myself from the pain, I ended up becoming very hopeless that as a 19-year-old I would never be able to do anything again. And I just ended up being fairly disabled. I didn't go for walks. I didn't get up anymore. I just sat around the house hoping that I would be able to somehow feel better. And finally I was referred to a neurologist for imaging, and the imaging showed no structural damage. And that led me down the opioid trail. So they gave me stronger and stronger opioids, leading to morphine, and those didn't help. And so then they would give me morphine and oxycodone, and those didn't help. And it wasn't until over a year after the accident that I went to see a physical therapist, but I was being given injections and all these different painful procedures that didn't help. And then finally, because this was due to a car accident, the lawyers were saying I was faking and that I just wanted attention. And I was in so much pain that I just couldn't, and I was so fearful that, and no one ever explained to me that, because it was so long ago, that, this is a normal thing and that there are so many different things associated with pain, and educated me on the importance of physical therapy and that relationship.
Yeah. So when they told you were faking it, what was your reaction, and what did you want to tell those people who said you were faking your pain?
It made me feel very hopeless. It made me feel very hurt because I just wanted to tell them I want to work. I want to go back to coaching. I want to go back to my life. I told them I'm a 19-year-old who was a gymnast and who loves coaching, and I told them those things, and they just didn't seem to care that I was very motivated, but I didn't understand how to get back to those things.
And so when you exhausted all sort of the chiropractor and the medical doctors, and how did you end up finding a physical therapist?
It was a long haul. So over the 4 years, I went from doctor to doctor to doctor, and at some points having doctors hang up the phone on me because they didn't know how to help me either. Um, and I ended up just finally having one doctor tell me, "We don't know what to do for you. You're just going to end up being in pain for the rest of your life." And that was kind of the last straw for me, where I was like, I am in my early 20s. I'm not willing to be disabled for the rest of my life. And I had gone to several different physical therapists, and some had very good intentions, but were not quite equipped to help me. And some were just were much more equipped and did a better job educating. And throughout that whole process, I just had to keep searching, because I knew I wasn't faking, and I knew I was motivated, and I knew that I didn't want to be on pain medication for the rest of my life. And so it was just kind of that whole journey of knowing in my heart that these people didn't know me, and that it wasn't me. And that just kind of led me down the journey of looking until I could find someone who was willing to work with me and listen to me.
That's great. So what made you go to PT school?
I kind of addressed that, but just seeing that there were some, that throughout this whole journey of working with doctors and pain specialists and psychologists and physical therapists, and seeing how if I had a more comprehensive treatment earlier on, I felt that I could have avoided the ongoing symptoms that I had, and that I felt that I had a story, and I could empathize with patients, and I could advocate for patients a lot better with the experiences that I've had.
Okay. So when the Tennessee Board of Physical Therapy this afternoon officially awards you your license, there's been a paperwork snafu, and she's only sent her transcripts 500 times. Anyway, so when you start your practice tomorrow, what do you hope to do?
Well, I've accepted a position with the rehab hospital in Chattanooga, where I live, and I'll be an outpatient, primarily working with neurologic conditions, and dizziness and neurologic conditions, but I'll also be working with chronic pain, and hopefully working to develop a multidisciplinary pain program with that hospital.
Great, thanks. Sarah, so tell us, as the academic on the panel, tell us about the profession of physical therapy. What do physical therapists do? Who do they treat, and what's their training?
That was a lot of questions.
Sorry.
So we, as you said earlier, I always say that you need a physical therapist when you are moving differently. If you've had a change in your ability to move, or you're trying to change how you move and you're not succeeding. That is always, to me, like the easiest way to think of what a physical therapist can do for you. Where we all have doctorate degrees at this point. So it's all a doctoral level education. And we work really with cradle to grave, and with every neurology, orthopedics, people with heart conditions, I teach pathophysiology to our students, and I always tell them, if you learn nothing from this class, exercise and being more fit helps all body systems function better. And it comes up over and over again, no matter what disease or body system you're talking about, being more fit and stronger and having better balance and just moving more and better helps with a wide range of physical problems. It helps with mental depression and anxiety and other problems. So we are involved really in every aspect of healthcare. We work in outpatient, in hospitals, in schools, in homes, in a bunch of different settings. And we are increasingly looking to be on interdisciplinary teams. And I think generally PTs are pretty open to that. And we'll discuss some barriers relative to that in a sec.
Great. So tell us about the patients that are part of the Power Over Pain program at the Stephen and Sandra Shelter, 11th Street Family Health Services.
Yes, it's a mouthful.
It is long. It's long.
So our clinic, it's a federally qualified health center. We're situated between 4 different housing projects in Philadelphia, and we treat all of the patients in the neighborhood, and a lot of patients commute to come in because we serve, we take people that aren't insured. So most of our patients have Medicaid or are not insured at all. It's a primarily African-American population, although we get people from literally everywhere. Google Translate is my friend. And I have a lot of Spanish-speaking patients, and I would say the majority of my patients are women, and middle-aged women is the majority, but it's really all over the place. Pennsylvania has CHIP, so kids are pretty well insured, and then after 65 you get Medicare, so we do tend to see people in the range in between that at 11th Street.
And can you tell folks here, what do you mean when you talk about an interdisciplinary approach, and why is it appropriate?
So our Power Over Pain group that we have, and just the way that our center functions for everything, is very much interprofessional, meaning not that patients see a bunch of different professions who sort of think on their own in silos, but that the care is really coordinated among professions. And the way that I teach this to my students is I say, if you have a patient and they enter the healthcare system and they see a PT and they get a piece of education and a little bit of homework from the PT, and they see the doctor and they get some education and some homework, and they see on and on and on and on. They're seeing all these different people, and they're getting, especially as they're more and more complex. So the more complex the patient is, the more different providers they're seeing, and each provider is giving them some education, and each provider has something they want them to do, right? We always tell people what to do in healthcare. So if that gets to be too much for a patient, and we're not coordinating ourselves in healthcare, that kind of leaves the patient there to prioritize, like, what can they fit in, what can't they fit in. Sometimes there's conflicts, like one person tells them one thing, one person tells them something else, and the patient's really left to sort that out on their own. So you could call that multidisciplinary care, but that's really not what we mean with multidisciplinary or interprofessional care. What interprofessional really means is that we are getting together as healthcare providers, as the team. We are all sitting down and saying what we think needs to happen from our perspective, and then as a group, we're really sitting down and prioritizing that and figuring out what the patient needs now, what can wait till later, and we are giving the patient one plan of care that has all of our stuff in it that the patient can actually follow. It's less confusing, it's more clear. We're prioritizing, and that interprofessional team always includes the patient. Because I always say the patient is the expert on themselves. So how much homework can they do? How much can they learn? How fast can they learn it? Those are only things your patient can tell you. So the patient really needs to be part of that decision-making team.
Explain to these folks how you pay for these services, and what kind of barriers does the regular insurance system present?
So our PT services, my PT services are completely pro bono. I teach at Drexel, and my department basically gives me a 40% buyout from teaching so that I can be at the clinic 2 days a week. And of course, students rotate through the clinic, and they do pay they have like a half a credit course where they rotate through a variety of clinics, 11th Street among them, and that helps offset my 40%, but basically my department eats that cost so that the students can get experience, and because we believe in giving back to the community we teach in. It is an unbelievable luxury to work without insurance. Every time I tell another healthcare provider that I don't have to deal with insurance, they're like, amazing, So I think there are a lot of barriers with insurance. Now, I did work for 10 years prior to being at 11th Street with insurance, never going back. And I think there's a huge amount of barriers. Certainly, PT is typically issued a couple times a week, and if your copays are $50, there aren't that many people who can afford those kinds of copays. It depends on people's insurance structure, so if they have a high deductible, or depending on what kind of insurance plan they have. But the out-of-pocket costs for patients can be very limiting for people who have insurance but don't necessarily have the financial means to shoulder a couple $100s a month, which it could be easily in copays or however your insurance is structured. I think the other issue with insurance is timeframes. So if you have, like, a lot of the HMOs will say, well, you have 60 days per diagnosis per lifetime for something. For me, I deal with chronic conditions all the time, and our healthcare system and our reimbursement system is largely geared more towards acute problems. So I think that's certainly true in PT, where, you know, oh, you're going to see a PT for a couple times a week for this many weeks. Well, if you have a chronic problem that isn't going away, and my job is to help you manage it, that doesn't make any sense. I'd rather see you once a month for the entire year for my 12 visits than 3 times a week for a month for my 12 visits. And a lot of insurance companies don't give you that option to dose the care how you want. I've always said I'd rather have restricted visits than restricted timeframes. But I think also with chronic conditions, people, even the limited visits, especially if those visits are, if they don't have very many, it can be really challenging, because if you have a complex problem, especially when that needs an interdisciplinary team, it's very difficult to manage that quickly. You know, people need time, and they need to learn how to take care of themselves, and we are their mentors in that in healthcare. And if you really look at a mentorship model, it's not just here's a piece of paper and a handout and now you can manage yourself. It really takes feedback and time and really working with somebody. And I don't think reimbursement usually gives enough time for us to really teach people how to take care of themselves, which ultimately is the most cost-saving thing we can do, is get people able to care for themselves and manage their issues, at least to some degree, on their own.
Great. Would you talk through maybe either a real or a hypothetical client and just what kind of services they get, what their conditions are, and how you've seen somebody make progress?
Sure. So I have a patient in mind who I'm writing an article about right now, so it's very fresh. But before I get into that, I do want to say, like, Jen's story, I've heard that story in various forms 1,000 times. Just so much, where people enter the healthcare system wanting help and just don't get it, and they spiral and they lose out on life. They lose out on days at work. They drop out of school. I mean, I have a zillion stories that sort of support all of the experiences you've had. With the patient I'm going to talk about now, she is a patient who came in with an ankle sprain, pretty standard ankle sprain, nothing too much there. Typically, we'd expect that to get better in a couple of weeks, but this was a patient who had a lot of stress. She had a job that she really felt pressured to perform in and didn't feel like she was going to be given any help or any time off, and was very concerned about appearing like she couldn't do stuff, so she was totally overdoing it at work because she was worried about getting fired, basically, and being perceived as lazy or as trying to get over or something like that. And she came in just with a lot of fear, which you brought up, and it was making her pain worse because she was avoiding walking on it. So I think Jen hit on a lot of these things. You're scared, and when you're scared, you avoid doing things, and when you avoid doing things, you get weak, you get stiff, you gain weight, you lose your fitness, and all of those things are bad for pain. And anxiety and fear are also bad for pain. I mean, this pain is a protector, right? So the more scared you are, the more painful it's going to be. So she came in with just a lot of issues. She had a lot of stress in her personal life, and she had some childhood trauma and just a whole lot going on. She had a kid who was just giving her, a teenage child who was giving her a lot of challenge, and not a particularly supportive home. And like, she was the support in her home environment as opposed to being supported in her home environment. And so we looked at her and we're like, she's totally going down the wrong path of chronic pain instead of down the path of healing. And it really nothing to do with her actual injury. It had just triggered all of this fear and other stuff going on with her. So we had an art therapist that was working with us there in the PT clinic. So she was doing drawings so that, like, the patient would do a drawing and the art therapist would help us understand the pain experience in a broader way, as opposed to, like, rate your pain between 0 and 10. How worried are you about it? The art therapist really helped us understand in a much more global way. Her first drawing was like, like crayons that looked like she'd drawn it like this, and it was like a black skull and crossbones and like red lines all over the place. And I remember saying, I was like, I'm no art therapist, but I'm feeling like this person's a little stressed. And she was. And so we ended up getting a lot of information, both because we routinely ask about those sorts of things at 11th Street, but also because the art therapist was getting a lot more detail. And we were sharing information. And so this was someone who we really felt was on the way to developing chronic pain, and we really worked hard to like calm her fears down, give her a lot of information about ankle sprains, how they heal, what to expect, what healing is going to be like, so she knew what was coming and knew what to expect instead of just, having every little pain she felt. She was like, oh no, it's getting worse, So we did a lot of education, and we really progressed slowly. We didn't scare her more by making her feel like PT was going to hurt her. And we really collaborated with the art therapist who, kind of addressed some of her fear and anxiety and some of her other mental health concerns as we were addressing her physical concerns. And we really collaborated and worked back and forth. So our practice informed hers, her practice informed ours. And we really tried to deliver that one plan of care I was talking about earlier. And so anyway, she ended up going back to work and doing great. And subsequently, a couple years later, she came back into the clinic, and ankle was fine, never had another problem with her ankle, but had since developed a neck problem, did not come to our clinic. She ended up it was a car accident, so she went to a lawyer who sent her to like their person who sent, so she ended up in this place where she really didn't get quality care, and she did develop chronic pain. She lost her job. She ended up getting a surgery, another surgery, was on pain meds, and ended up getting a device placed in her neck for pain. I mean, it went completely downhill. So obviously, I can't prove anything about that, but I really feel like she was headed that direction with the ankle, and we were able to turn that around with a comprehensive approach. And then when she had another interaction with the healthcare system that didn't give her that, it really went in a bad direction. And I think, if you look at total cost, lots of surgeries and losing one's job and not being able to take care of her kids, and she was the glue in her family, and she was really failing in that at this point because she was in so much pain and not able to make money. And I think I hear those kinds of stories all the time, and I really think there's a lot we can do in healthcare to make that simpler and less expensive and a better experience for the patient.
Okay, great. And Cindy, tell us about Elliot and what happened to him when he was playing high school sports.
First of all, I'm looking out here, and you did warn me that I'd be speaking to people who look a lot like my son, and then who comes in but a redheaded gentleman, and that is my boy, my redheaded fireball. Elliot injured his shoulder playing football his senior year, and he was not going to play football. So we took him to a sports medicine doctor who basically said, your injury is not going to get worse if you continue to play. It is going to hurt, and gave him a prescription for an opioid painkiller. And there was no information given to me as a parent with reference to the possibility of this being an addictive or a potentially addictive medication. And as a parent, and one thing that we all have in common is we've all had to have parents, and we do the best that we can with the knowledge that we have. And I know I would do anything that I could to make life good for my children, and I think you probably can attest to that as well with your parent or guardian. So he was taking the pain medication. When that ran out, he was at that point not telling me about it, not really being open and completely honest with the trainer, because he wanted to keep playing. They'd ice it after a game. But another young man on the team had been given a prescription, and so he was just giving Elliot his meds in order to mask the pain so he could continue playing. Well, the football season ended. He was going to play ball at a smaller university, so looking forward to that. But then he really found that he liked the feeling that he got when he was taking those pain meds. And so that continued, and eventually that led to heroin down the road. When the painkillers are no longer being offered up by the physicians, people will look for an alternative, and a less expensive alternative and very accessible alternative was heroin. And by the time this happened, he was off to school. First time he experienced withdrawals was at football camp in college, and I thought he was just had the flu or something, and he didn't even know because he'd never experienced withdrawals. But he made it through that time frame. But then toward the end of football season, the friends that he had been involved with, who had been using, would come visit him at school. They would bring things, and by the end of that semester, he was full-blown addict and dropped out of school, and it was off to the races at that point. So, which included, at the worst point, he was stealing in order to support his habit. He was never one to break in and steal things from people's houses, but if he were in someone's house, then he would take things and go pawn them. I finally got to the point in our home where, and I'm still this way, things just don't matter all that much because things can be replaced, but anything of value was at one point taken and pawned. He was arrested, numerous attempts at getting him into treatment, but when we first started this whole journey to get him into treatment, people don't accept you into treatment with a heroin addiction because you don't die from withdrawals from heroin. But my argument was, well, you die when you are withdrawing and you go out and you use again, and then you overdose and then you die. So numerous overdoses. The last overdose that he experienced was at home, and by this point in Indiana, they had started allowing for people to get Narcan, which is the reversal drug. CVS or other pharmacies were selling it without a prescription, and I had gone, because I was educating myself every step of the way, I had gone and purchased 2 doses of Narcan. Well, we were at home one day, and he went in to take a shower, and something just didn't feel right, and then I heard just a thud, and I yelled his name out, and he kind of mumbled something, and I thought he's all right, and then I yelled his name again, and there was no reply, and I banged on the door, no reply, and I busted in the door, and there's my son laying on the floor, not breathing or barely breathing, slight gasps, and lips blue, and I just went into, I don't know, I still have people ask me, how did you do it? And I don't know how I managed it. Number one, I need reading glasses. I can't see anything if I don't have my reading glasses on, but I was able to put the kit together. and administer the Narcan while calling 911 at the same time. And then it took 2 doses of Narcan to get him breathing again. And the way that I ended up here, Elliot should be with me, but he got a year clean and then he relapsed. And now he's been missing for 3 days. And that is one of the worst fears that any parent should ever have to go through, is not knowing where their child is and what's going on with them. And it just runs through my mind all the time that if someone would have given us an option other than pain meds when he was 17 years old, where might we be right now? Elliot could be sitting right now where you are. And instead, I don't know where he is. And there are so many other things that should be done rather than go immediately to a pharmacological method of treating pain. That, in my opinion, except for in obvious situations, that should be the last thing that we're doing. And knowledge and explaining what this can do to an individual is crucial. And prevention is necessary. There are so many things that, as a high school teacher, we have all these unfunded mandates that we are supposed to do for these children, and we do, but one thing that we're dropping the ball on is drugs and alcohol and tobacco. We're making the assumption that these kids are getting this information because it's been around for a long time. We've been dealing with this. We have, DARE, we have all these programs. My son was the DARE Student of the Year. He and I were joking when we found the little medallion that he got as a 6th grader because he wrote a great essay. He didn't ask to become an addict. Nobody wakes up and says, I want to be an addict. He has goals and things that he wants to accomplish as well. And we have got to do something, and it's got to start on the level where, right here and right now. And that's what we need to be doing. We need to be doing that, preventing it in the first place whenever possible, and convincing policymakers that this is so important is what we're all hoping to do.
Thank you. I met Cindy and Elliot in January, and he is a highly confident, high-spirited, fun, not so young man. And their banter back and forth was so much fun to watch. So here we are 4 months later, and it's not the same. So again, when I started, addiction's really hard to fight. Addiction's really hard to fight. And if we can help people not ever have to go down this road because prescribers know more, athletic directors know more, coaches know more, your primary care doctor knows more. Hopefully we can, with your help, we can have fewer people be in the situation that Cindy and Elliot are in now. Cindy, one final thing. If Elliot was here today, what would he want to say to these folks?
I had a lot of friends asking me, are you still going to go to DC? How are you going to do that? Because the struggle's real. I mean, we've got missing person alerts out for him. Elliot would throw a fit if he thought that I wasn't going to come, because for us, this is, a lot of people want to stigmatize addiction and they want to hide it. Elliot's not like that. And because he's open about his disease, I feel like I can be open about that as well. And he would want everyone to know that there is hope, There is hope. He's had, in the past really 3 years, he's probably only used a month and a half out of that time. So he's had more clean time than he hasn't. And his job was to get people into treatment. And he would want everybody to know we need to prevent, we need to make treatment more accessible. People shouldn't have to suffer in silence. They shouldn't have to, there's just not enough programs available for people without insurance. This was the real kicker. He was employed when he just recently had his relapse. The insurance that he had through the treatment center that he worked for didn't cover the addiction treatment that he needed. What is that about? So he got scholarshiped in somewhere because he knew people, because his platform is social media and going on to social media and reaching out to people. And his biggest thing is to get people into treatment, because he has lost his best friend to an overdose, and he just wants accessible treatment, and that's what he would be asking for. Please make treatment accessible, and prevention opportunities in schools where people can afford to get kids out of the classroom and not just hand them a pamphlet.
Thank you. We have time for some questions, if you guys have questions. Yeah, go ahead.
I'm Greg with Congressman Winstrom's office. Our district is Dreamland, the book, if you've read that. The opioid, the cover is in our district. But I was curious on the physical therapy side and your statement, the length of time versus the number of visits. Have any PT practices do or looked at kind of the Netflix model that we're seeing with direct primary care, or are insurers allowing that, where we're going to give you X amount of money for a year and you get to set that up with the patient on how you see fit? Does that exist anywhere?
I haven't seen a ton of that. I don't know if APTA has. No. And like I said, I would prefer to be limited in a number of visits that I got to dose as I felt was appropriate than be given a time frame on that.
Do you think something where it's not even a number of visits, like we're going to pay for 12, but we're going to give you X amount of money for 3 months, and you get to determine with your patient how to do that? Would that be something that PT would be interested in?
I think I'd rather have X amount of money without a time frame. I mean, even if it was the same amount of money, like having to spend it in a time frame, I feel like for chronic disease just very much limits my dosing options. Because for chronic disease and somebody who's doing a pretty good job in their self-management, certainly in the beginning when they're learning, maybe I'm seeing them frequently, but I have a lot of patients that I see once a month or once every other month because they're basically self-managing, but then they have a question or they have a flare-up and they need to be able to check in with me. And I would always like to be able to save, like, maybe I'll see you a bunch in the beginning, but then I want you to have a couple visits for the rest of the year. So I think a dollar amount or visit amount or whatever, so long as it wasn't a time frame limit, would be preferable.
Yeah, I think this whole concept of a bundle, it can work if the bundle has some evidence behind it on what sort of the number is, and access to the kinds of, as Sarah was saying, the different kinds of practitioners who may need to participate in somebody's care. So that can be done with a bundled rate that can work, but you can't just pull a number out of the sky and say, here's $10,000, knock yourself out, because that may not be. That might be the right number. It might be the wrong number. So you want to have some sort of data going in to develop what that number should be.
And I would just add to that, like, one of the things that doesn't really get reimbursed is talking. So my ability to coordinate, like, I get paid well, mine's pro bono, but healthcare providers typically get paid for the time they spend with a patient. And of course, that's important, but the time I spend coordinating that patient's care with their other providers or just talking to that patient and giving them advice as opposed to doing an intervention with them is equally valuable and essential to a good outcome. And so I think the fact that that's never reimbursed and it's always on, our nights and weekends, and we're all in healthcare, and we got into healthcare to help people, and most healthcare providers do stay late and make those phone calls. And I have lots of doctors' cell phones, and we talk in the evenings and on the weekends about patients, but that's all kind of on us, and obviously every healthcare provider doesn't do that.
That sounds like a teacher.
Yeah.
Yes, go ahead.
Ray Celeste with the 3rd District of North Carolina, formerly Congressman Jones's office. Our district has really 2 segments. One is heavy with military, so we've dealt with a lot of military members coming back with PTSD and TBI. And so Mr. Jones, who unfortunately recently passed away, but he was a big advocate of I don't know what you call these alternative medical things, procedures such as hyperbaric oxygen, like you mentioned Elliot with the shoulder. Like we have a relationship with the NFL Pro Football Association, and they're big advocates of that. Maybe that would have cured his shoulder if he had gone through those treatments. He wouldn't have needed any painkillers. But I'm just getting at, do you all think like hyperbaric oxygen therapy is a good alternative, perhaps for some of these injuries, which may cure it? No need any painkillers. And also, he was an advocate of things like acupuncture. Like at one of the hospitals in our district, they don't know how it works. They put these pins. It's called combat acupuncture. No clinical study. They put a bunch of pins in somebody's ear. And for some people that works. We don't know if it's the placebo effect or not. And then things like yoga. But anyway, his big thing for PTSD and TBI was doing treatments of hyperbaric oxygen. He thought that was a good method that should be tried. And if it's a placebo effect, so what? It works.
So I'm always a firm believer in the placebo effect. There's a reason why we have controls. And, if you do a blood pressure study and give half the people blood pressure medication and half the people a sugar pill, the people with the sugar pill, their blood pressure goes down and there's no side effects. So if you can get placebo to work, I'm all in. And I feel like that's underutilized in medicine a lot. Pain is really subjective, so I always tell my patients, if you think you have less pain, then boom, you have less pain. So I had I don't know if you guys remember, you're all young, but magnet therapy was really in style once, and they had these like calibrated little magnets that they did, and so we had a patient come in once with like Pizza Hut magnets, like the refrigerator ones, like taped around his ankle. And he'd been scared to move, and he was limping and limping and limping, and he walks in one day like totally normal, and I was like, what happened to you? And he's lifted up his pant leg, he's like, I got the magnets, and people are like, what did you tell him to do? I'm like, as long as he walks normal, he's going to get better. So to me, use the magnets. I have a patient who puts a bar of soap under her sheets at night because, I don't know, somebody told her that made your pain go away. And I said, does it make you feel better? She said, yes. I said, well, go for it, So the evidence on hyperbaric oxygen, I'm not going to pretend like I'm super up to date on it, but I don't know if anybody else here knows about it.
If I could just
Yeah.
interject, like, that was something that we heard all about the clinical studies, but the cocktail of drugs, his response would always be, there's no clinical evidence on all these cocktail of drugs they're giving.
Right.
Absolutely.
Correct.
And you're just in a hyperbaric oxygen chamber, as you know, it's just enriched oxygen.
Right.
So what's the big deal?
Right.
Why all this emphasis on clinical study? On one thing, hyperbaric oxygen, and on these drugs, no, you can just give that young man or woman try this drug, that drug, this drug.
Well, certainly.
And then they're, bad things happen.
Yeah, I mean, preferable to a drug, for sure, and preferable to an opioid. I think, hyperbaric oxygen is really expensive, and so there may be less expensive ways to get at the same thing. But to me, like you brought up acupuncture, yoga, I mean, this is, we offer a lot of those kinds of services at 11th Street. And one of our sort of philosophies at 11th Street is, you know, there's no wrong way to feel better. And we try to have a lot of options for people because some people, you put them in a hyperbaric, you know, they get better. And other people do a little meditation or mindfulness and they get better. And other people like, you know, what, you know, you're going to get, what there is tons of evidence on is if you are doing a treatment that you believe will work, it is probably going to work. There's plenty of evidence on that. If you have a provider that you trust and have a good rapport with that is giving you a treatment that you believe in, you are much more likely to have a better outcome regardless of treatment and regardless of profession that spans lots of things. We can thank our mental health providers for a lot of that research. And so I think what that mix is for each individual is really different. So we try to have just a lot of options for people so they can find something that clicks for them. And I think no matter what treatment you look at, there are people that it works for and there are people that it doesn't work for. So I don't necessarily feel like we pigeonhole people into one treatment. I think people do need options.
Hi, good to see you, Katie. Laurel Stein with the American Psychological Association. I just wanted to make a comment. I came a little late, but I applaud you for sharing your expertise and your experiences. Our psychologists really value the role of physical therapists in this approach to pain management, and just pleased to have you here for this forum.
We value you too.
Yeah, thanks. Yes, sir.
Zaire from Congressman Reschenthaler's office, Pennsylvania's 14th district. So Western Pennsylvania, southwestern Pennsylvania in particular, very blue-collar, working-class area. There's one thing about our society in Western Pennsylvania that isn't what I like the most, but there's a lot of drug trafficking over there. Fentanyl is something that's bad over there, but heroin and opioids, of course. I really think that one big part of that comes from the working class society, and you know, there's a lot of people over there that have money that can, you know, afford to fire somebody and hire somebody else. Because there's a lot of people that I can hire him if you're not going to be here, basically. So then it gets into the point where there's no other job. There's not too many small businesses. There's nothing else. So then people start to, you know, move on to depression, and that's one of the things is drugs. In high school, I went to Washington High School in a district, so I'm from the district. One thing that we could do was actually get our physical training certificate in high school. But something that we don't have is, you know, talking to the students about drugs, like you said, like what we should have in high schools. We do have the DARE program, but that ends in like 6th grade.
Right.
So what would you propose is something that high school students could use along with physical therapy to, you know, combat that issue?
Okay. Again, I'm a high school teacher, and my master's is in school counseling. So I never believe that a one-and-done kind of thing is beneficial, you know, where you bring in a speaker and, you know, they share information and then they leave and then nothing else is said about it. I know in Indiana, kids can even take health class now online, and there's, I don't know, I've seen too many of my students that I've heard them talk about what their PE online has been like and their health class online is like. And, you know, if we're going to incorporate it into curriculum, then, you know, your health class is a class where that would be, you know, it would be incorporated and mandatory in the curriculum itself. And there's always snippets of things, but really what has to happen is there has to be buy-in from your administration. And if it's not filtering down from above, so the only way you can get above is, you know, from the state level, and then the only way you get above that is from the federal level. So it has to come from somebody that says, you need to do this, and it needs to cover this information for at least this amount of time, and kids need to be, it has to be a realistic kind of situation as well. The DARE program actually is, and I'm not trying to bash anything, my husband used to be a police officer, but the way that that is, that information is disseminated has really been proven not to really necessarily be all that effective. And we can't stop at 6th grade. It's something that has to be incorporated all the way through. Because in 6th grade, you can convince a 6th grader, that, oh, drugs are bad, but then, they experiment with marijuana one time, and they're like, this isn't so bad. I didn't die from that, And so now they've got this skewed opinion that maybe all that stuff that we learned wasn't really truthful and honest in the first place. So whoever is giving that information needs to know what they're talking about. So they do need to have people coming in from the outside, but it needs to be, people in recovery who are trained to do this, and it needs to extend over, a longer period of time. And it needs to be, your freshman year, your sophomore year, your junior year, your senior year, because it looks different every time. And the more we can reduce the stigma, then the more likely we are also of kids to feel like they can open up and that they can share about this. They are not going to share with a police officer in the classroom when their best friend is experimenting with opioids out of their parents' medicine cabinet. So it's all about who's doing it and how much we're doing it. Does that make sense? Okay.
Yeah, go ahead.
I know we have a couple minutes left, but I was just curious if you could speak more to the role of physical therapy with chronic pain, and does it generally wean people off opioids, or is it a complement and that's kind of a decision they have to come to themselves, or how you work with patients in that position?
Jen, what was your experience?
I think it's a compliment. I think it needs to be a decision made between the patient and their doctor and their physical therapy provider. And that's something that needs to be done over, just because pain is a journey. It's something that, especially when it is chronic and that sensitization happens, it becomes a lifelong journey. And the goal is to be off the opioids and to be managed conservatively, and to manage that pain through exercise and through things like yoga and mindfulness and through those type of things and through physical therapy. But it needs to be that multidisciplinary approach, because physical therapists, medication isn't in our education, in our scope of care. So it really needs to be something that's a shared decision.
And I'll add to that part of, so if you're going to use physical therapy as your new pain management, or whatever else as your new pain management, you are tapering someone off opioids, hopefully paced with the effectiveness of whatever's taking it over. So I don't think you can just put someone on a taper. You need to, the information we can provide as physical therapists is, reasonably, how long do we think it's going to take for what we're doing to be effective? And you might want to match the taper to how long it's going to take to actually get strength gains, or actually do whatever it is that we're working on, or whatever other intervention. So I think that's also where the interdisciplinary approach comes in. I actually have two little patient stories to address yours if we have time.
Yeah, go ahead.
This was years back when I was working in the hospital. We had a patient who had a bit of a cocaine habit, and sometimes if you snort too much cocaine, you can get a stroke. And so he had been in the hospital with multiple strokes and had recovered really well from all of them. And I was going in to treat him, and he, he's young, he's going to go back and hang out with his same friends, and he had asked the doctors, basically he wanted to know how dangerous was it for him to party, is how he phrased it. And the doctors told him, no, don't do anything, you can't do anything, you just had brain damage, blah, blah, blah. And he asked me, and I could tell that he was not quite, believing with it. And so I think being really frank with people and giving them actual information and not just trying to scare the crap out of them is really important. So I told him, look, you just had a brain injury. Like, I would leave your brain alone for a while and let it heal. But is, smoking a little bit of pot or drinking a beer going to give you another stroke? Like, factually, no. I certainly wouldn't snort any more cocaine. But, he was like, okay, like, he really wanted to know what his parameters were, and he knew that it wasn't being given to him by just don't do anything ever, because you can look around you and see that that's not true, right? So he really needed actual information to, he wanted to take care of himself, but knew that he wasn't going to totally do it all the way, and he just needed parameters. To speak to you, I think I had a patient who he got shot, he got chronic pain, he didn't really get good health care in the beginning, and he had had chronic pain for many, many years, and he really had like permanent nerve damage and stuff that wasn't necessarily going to get better. His foot was very deformed and difficult to walk on, young guy. And he was on pain meds because that's what they gave him when he left the hospital, and he'd had a prescription for them for numerous years, and his PA actually had a good relation. He's one of those people where we were in cell phone contact, and he would call me up and say like, oh, I really want to wean him, but it's really hard. And I was saying, I was having trouble in weaning him also. Like, I was having trouble getting him to get better in therapy. But basically, we kind of got together and made a plan. We both told him the same plan. He started off on it, kind of fell off. Neither one of us saw him for about a year. He came back a year later, and he said, I couldn't really get off the pain meds because he was in pain. And I don't think that we in healthcare, or, I don't think the public in general understands how totally terrifying it is for someone who's in pain to be asked to not take the pain meds, right? It's totally counterintuitive for the person in pain, and it's scary. So he came back and he wasn't using any pain medications, and what he said was, he was like, you told me, my PA told me, and I was just sitting there at Thanksgiving with my family, and I was feeling awful, and just like what you told me and the PA told me just kept running in my head, and I just decided to stop. So this was someone who tapered himself slowly on his own because we had talked to him about how to taper properly, and he'd done it all on his own with information at a time that he was ready. But I think hearing it not from one person but from two people, and really having that coordinated care but also good information, allowed him to do it essentially on his own.
Okay. Thank you all for coming. This has been great to have you all here with us. I want to ask the panel just for one final thought, and then we'll close up. Anything else you want folks to know? Cindy, why don't we start with you?
I think to understand that addiction happens to anybody. It doesn't matter your age, your socioeconomics, your race, your, anything. It can happen to anybody. And to try to work toward prevention in any way that we possibly can, no matter what the situation is, I think is important.
So I'll say my final thought is, I think that pain and opioid use and substance use disorders are really, really complex. And when you have complex problems, you need lots of different people from lots of different disciplines. I'm not talking just healthcare, but you guys, public health, it goes on and on, really working together for solutions. And I think that, and a lot of prevention goes a long way. So in most of the cases that I see where people are really struggling with pain and opioid use and it's spiraling out of control, those people could have been deterred from that path with better, more coordinated care and better access to care. So I do think that spending money in the beginning saves a lot of money in the end, and that we can't just look within industry. So an insurance company might not feel that way, but if we factor in lost wages, somebody who's now on disability because they're not working, if we look at total cost to society, it's a no-brainer.
And I think I'd like to build on that, just saying that once pain becomes a chronic process, it's a lifelong disorder, and that each person's journey with pain is unique, and the treatment that they need is unique, and their time frame is unique, and the relationship that they have with their healthcare provider needs to be unique.
Great, thank you. One final thought. If you didn't get a pack of information when you walked in, please do. We've got a white paper that sort of talks about all the things we've talked about today. We've got a one-pager that cites the peer-reviewed research that helps support the things that we're saying, so it isn't just us saying it, it's actually real scientists saying it, although all of you are real scientists in your own way. If you go to our website, there's a button for the public, and you'll see our Choose PT campaign, which has a lot of information that hopefully can be helpful to you as you're helping constituents try to figure out what's next. So thank you so much for coming. We really appreciate your time and attention. Take some food back to your office if you can. We will also be sending this information to you electronically tomorrow. So again, thank you so much for being here. We really appreciate your time.